Good afternoon. It is a great pleasure to be asked to present at the German conference of the German Society of Phlebology. I'm going to talk today about risk assessment, the Tangled Hemostatic Web, and COVID-19. Here are my disclosures. Today, we're going to try to understand the value of risk assessment for patients suffering from the coronavirus, learn about specific risk factors and the role of intermittent pneumatic compression in medical, surgical, and COVID-19 patients, and update the current recommendations regarding the coronavirus. A discussion regarding the Tangled Hemostatic Web will be entertained, as well as presenting the American Venous Forum guidelines for patients with the coronavirus. Finally, we'll close with description of the future therapeutic options to address hematologic and immunologic changes in patients with coronavirus. Now, there are many roads to Rome, but we know now that there is, it's very important to have a risk assessment of patients. We prefer the Caprini Risk Assessment because it's the most comprehensive list of risk factors ever produced that has been validated. And there are now about 180 articles in about 5 million patients that have reported on the score and shown the value of the score in most of those cases to be associated with the venous thromboembolism. So we know it's a thorough history and physical comprising 40 elements. We also know that as the number of risk factors goes up, the incidence of venous thrombosis goes up. As the power of each risk factor is graded, putting those grades together gives an overall estimate of the incidence of thrombosis. So combining the number and the power of the risk factors results in a score. And that score represents a nonlinear increase in the clinical venous thromboembolism rate as the score goes up. So as the score goes up, the DVT rate goes up, and here's a typical example in general surgical patients. Capturing all 40 elements in the Caprini score is a time-consuming process, but the collection is facilitated by having the patient complete a patient-friendly form in advance of elective surgery, ideal with the help of the family relatives. It's very important to engage your family in this. Families should assist in this because often you can remember different details and they will remember different details about your history. And the purpose of doing this at a specific time is that's when your focus is on your risk. Not when you get sick, not when you come in for an operation, because there are other things on your mind at those times. Once the family puts this together with you, you ought to run it by your healthcare professional or primary physician so that they can make it a final document and also put it in your medical record for use later in case you get sick or have to have an operation. This patient-friendly form has now been validated in a half a dozen languages and is a very easy document to use. Here we can see the layout of the document, which is available online, of course. And again, this is the second page of that. And what's really important is once that you get your score, the score isn't a static element. And oftentimes I've seen doctors, every now and then we'll get a publication that comes out that says the Caprini score didn't work. And what one of the mistakes that was made was doing the score at admission and then following the patient through a complicated illness and not updating the score. For example, if you have a patient come in with a simple gallbladder, but then postoperatively they leak, maybe they have to be reoperated on, they may need an ERCP, they may develop infection, a central line, or even in some cases where you do biopsies, cancers are noted when the biopsy comes back. So this is the score has to be updated because often that will result in a change in the thrombosis prophylaxis, including the post-discharge prophylaxis. You really need to do a score at discharge. That's a very important feature of this whole process. Now, there's some preliminary data that we have put together, and it's in the process of being reviewed by it was done by Professor Cyril Lobostov in Russia, who did a beautiful job with this and showed that it is helpful. And what we consider is patients with a coronavirus positive that are asymptomatic, we add an extra score of 2 points. If they become symptomatic, it's 3 points, and if they have a positive D-dimer, it's 5 points. You add, of course, that all of their other risks, and in case they're going to have surgery, the surgical risks. And remember to update the score during hospitalization. Now, I'd like to point out that it's very important that we talk about time of anesthesia. People talk about doing quick procedures and minor surgical procedures, such as a simple appendectomy, a simple arthroscopy. But any of those procedures that require an anesthetic, that brings other things into play. And it really is the embodiment of Virchow's triad, which is, of venous stasis, endothelial injury, and hypercoagulability. And that all occurs when the patient is put to sleep or gets a spinal epidural anesthetic. First of all, venous stasis occurs because the muscles all relax in the calves and the veins can dilate as a result of that. When they dilate, they become over-distended. And of course, as they're full of blood, the blood is static there. But the blood is being infused with products of metabolism and waste products from the tissues. So you have a hypercoagulability occurring according to that. So put this all together. You have dilatation of the vein walls so they crack, so you have vascular injury. You have venous stasis where the blood is puddling in the leg. And then you have hypercoagulability due to the effects of the metabolites and the static blood sitting there in contact with the subendothelial collagen. It's a perfect milieu. It's a perfect laboratory experiment for venous thromboembolism. And that's why it's so important to use pneumatic compression on both legs during the operative procedure. And if there's a problem using the legs, you can always use a foot pump. But it's very, very important to do that. And also, of course, to put a little pillow under the knee, because if the knee is straight, then you could compromise the popliteal vein and have so-called popliteal vein entrapment, which would slow down further the flow and increase the intensity of the thrombotic-like response. So we consider surgical procedures requiring 45 minutes of general or regional anesthesia as major from the thrombosis standpoint. They may be minor from the surgical standpoint, but not from the thrombosis standpoint. The longer the procedure, the greater the risk. And we know from work going back to Maxwell Borough in 1981 and 83, that if the surgery went over 2 hours, the risk doubled from 20 to 40% and went up to 60% if the surgery was over 3 hours in his series of experiments with venograms. So we know that time of surgery is important, the time of anesthesia is important. And the pneumatic compression devices on the legs or feet help to minimize this effect of this laboratory experiment of thrombosis. Now, unfortunately, we've gotten some very serious data regarding operating on COVID-2 patients, positive patients. And it has been shown in at least one series, and there are more data now coming out all the time, that in 294 patients, the mortality at 30 days was 23%. Pulmonary complications were seen in half of the patients. And then when we went up to 30 days further, those patients that had pulmonary disease had an even higher risk of thrombosis, averaging 83%, and this involved over 82% of all the patients. Males in age over 70 were associated with an increase in morbidity, including deaths. We know that the novel coronavirus was first reported in Wuhan, China in 2019. And in this early series, which was very impactful, coagulation tests in 180 of these patients showed that the mortality was 11%, with elevated D-dimer and fibrin degradation products levels that were initially elevated in these patients. So when these patients came in with elevated D-dimers, fibrinogen, and fibrin splits, their risk of thrombosis, of death, was higher. And the platelet counts decrease, and the partial and thromboplastin time changes occur and get longer. Later in the disease, when you have a bleeding, a DIC-like picture. But that's not the common picture here. The picture of this disease is overwhelming thrombosis. In his series, Tang showed that this disseminated intravascular coagulation-like picture was seen in 71% of those that died, compared to only 1 who didn't. And the sepsis from the viral infection may lead to activation of clotting and fibrinolysis and the immunologic systems, the so-called Tangled hemostatic web. We'll discuss that in a little bit. The authors concluded that D-dimer and fibrin split product value levels may have prognostic significance and may be important therapeutic targets. Those changes have been seen many, many times in subsequent publications regarding the coronavirus. Now let's talk about Oskar Ratanoff, who was a famous hematologist who in 1971 put together his famous Tangle Web. And Oskar Ratanoff was one of the discoverers of the clotting cascade. He also discovered Hegeman factor in his patient John Hegeman, which is the contact activation factor, factor 12. And I'm going to read to you what he says. The thesis of my talk is not new. We think about clotting, fibrinolysis, immune reactions, and inflammation as if they were separate and separable process. In truth, these distinctions are man-made. In real life, it is the body as a whole that responds to the injury. The processes through which it defends itself are interlocked like the pieces of a jigsaw puzzle. We may be intrigued by the intricate nature of this puzzle, but the picture emerges only when they are put together. And that's why I've liked to talk about this, and I talked about this many years ago in burn patients as disseminated intravascular multiple systems activation, or DIMSA. And so here goes. When clotting factors get activated, and the clotting factor gets activated because of the foreign body in the bloodstream, the virus. And when that happens, platelets start to clump and they form platelet plugs. The clotting factors all start the clotting cascade starts, factors 12, 11, 8, 9, 5, 10 in calcium, and so forth, with the formation of thrombin and the conversion of fibrin to fibrin and fibrin mesh. Factor 13 makes it more stable. Fibrinolysis occurs, and fibrin split products are resulting in the circulation, and there is active fibrinolysis going on in the body at the same time. But that's just the beginning. The complement systems, C3, C4, C50, are also activated, as well as the kallikrein systems. And these are the inflammatory and antigen antibody type reactions that occur. And the results of all of this are the thrombosis, fibrinolysis, increased vascular permeability, vasodilatation, bradycardia, angioedema, histamine release, and hypotension. Now, believe me, these changes all occur. For example, they occur in a staphylococcal pneumonia. And in that disease, the cell walls, if you give penicillin, the cell walls of the staph are damaged, so the intracellular contents get into the bloodstream and trigger clotting. But now, with this COVID-19 pandemic, it's much worse, because not only do you have the foreign substances entering the bloodstream to trigger the tangled web, but you also have these spikes of protein from the virus that are facilitated through angiotensin II receptors that invade the cells. It's like a bee sting into each cell. And of particular attraction for this virus is the alveolar endothelial interface that you're seeing here. And a whole series of investigations and mechanisms have been shown now. The modern investigators since Oscar Ratnoff have done an incredible job in outlining and characterizing many of these things, like interleukin-1, interleukin-6, further evaluating the ACE2 inhibitors. The fact that nitrous oxide, when it's released from the endothelium throughout the body, causes vasodilatation. But in the lungs, it tends to cause vasoconstriction, as the lungs are trying to, lung vasculature is trying to prevent perfusion of unventilated areas. And there's also other types of mechanisms that are going on here all at one time. This is a nasty, nasty illness. Not only can you see that from your clinical results and morbidity and mortality, but look at what's going on at the cellular level. Now let's go back to factor 13, good old Hageman. When we've shown Hess has shown that levels of factor 12 in bronchoalveolar lavage fluids of ARDS patients are associated with clinical outcomes. Look at the difference between survivors and non-survivors in their factor 12 levels. Another thing I'd like to point out is the dramatic effects of heparins and related agents. And when you take a look at all the things you can do, you say, wow, no wonder this is the choice for treating this tangled web, if you will. Now, the other thing is, which I note here at the bottom, is the polyionic nature of heparin binds to proteins and is an effective inhibitor of the viral attachment. Wouldn't it be nice if this were the answer? But believe me, everyone, heparin, low molecular weight heparin, anticoagulation in general is not the total answer to this disease. It's one factor that's very, very important, of course. Remember what Ratnoff said about disciplines have to get together. The clotters, the anti-inflammatory doctors, the immunologic physicians and researchers, and all of those drugs. Everybody has to get together for this disease. Now, the American Venous Forum Subcommittee on COVID-19 has put out a few guidelines for us. And believe me, these are just suggestions. And a lot of these suggestions are based on experience we have in patients before COVID-19. It's now pretty well established, and since we wrote this, it's even more established. All patients that come into the hospital need low molecular weight heparin prophylaxis or heparin prophylaxis for the COVID illness. This is an endovascular illness. The lining of the blood vessels all over the body is affected. And if you can just picture this for a minute, imagine a single bee sting in every cell of the endothelium everywhere in the body. That's where that viral spike is going in with angiotensin II receptors. It's a terribly difficult disease. These patients all need to be risk assessed. I've seen some publications say, well, should we or shouldn't we risk assess? Are you kidding me? In all of the patients we've known now, all medical and surgical patients, prior to this illness, we need to evaluate those patients because some patients are at higher risk than others. Well, the same thing holds true in COVID. That puts another level of increased risk on these patients. And when you take a look at it, these patients who have comorbidities such as a BMI of over 35, multiple risk factors, including their ambulatory status. But don't forget about diabetes requiring insulin. Don't forget about heart failure, pulmonary failure, past history of thrombosis, venous thrombosis, and cancer. All of these things impact it. So you can't just give everybody the same low dose when they come into the hospital. We feel that you should give double the dose because that's what you do to protect these patients. And you know, time will tell when the trials are done whether or not we're right or wrong about this. But the risk of bleeding is very low in these patients. This is a disease of thrombosis. So unless you see an excessive amount of disease, then we feel that this is a particularly important policy to follow. Now, the authorities don't follow this policy, but I know one thing that's interesting. The authorities say that they do adjust for a high BMI, a little higher than this. Well, if they adjust for a high BMI, why wouldn't they adjust for all the other comorbidities? Doesn't make sense, but what can I tell you? Now, the other thing is, that you can't just score the patients on admission. You have to follow them through hospitalization. It's a dynamic tool. And then rescore them at discharge. And again, give them extended chemical prophylaxis for most patients. We'll get back to that in a minute. Measuring the tests initially, including the D-dimer and split products, are important. You might also want to measure fibrinogen levels. And your basic prophylaxis, don't use the new oral anticoagulants here. They're not established for that. There's a lot of different problems with that we can't get into right now. Low molecular weight heparin or unfractionated heparin is ideal for this disease. You have to adjust it for creatinine clearances, double the dose for scores of over 8. And then therapeutic anticoagulation has been used for a lot of patients on a very selective basis if they have presumed thrombosis, or even if they don't, but they're in ICU, on ventilators, and maybe their oxygen requirements are getting worse and worse. Those patients sometimes merit full anticoagulation. The detractors would say, well, Dr. Caprini, don't you realize there are pulmonary hemorrhages as a part of this disease? Of course I do. But the thing is, the overwhelming feature of this disease is thrombosis, and bleeding hasn't been a factor. And I think it's also improved the survival in selected patients who are in this very highest of category, as Tang showed us before in another category. The D-dimer being 3 times higher risk indicates a very, very high risk. And you can also, don't forget about fondaparinux for heparin-induced thrombocytopenia. And don't forget to use your mechanical compression devices. We don't have time to get into it now, but there's abundant literature that pneumatic compression devices enhance the value of anticoagulation. And of course, if you can't use anticoagulation, you must use those devices. Now let's go back in history. We've got to go back in history in order to understand what's happened. And we know in medical and surgical patients that in 2008, Professor Arcelis published this beautiful study from the RIETE database showing that 77% of people got their clots when they went home, and 55% after they had stopped prophylaxis. It befuddles me why the authorities, even to this day, don't recommend stopping anticoagulation when you go home. And now what's happened in 2017, there's some brand new data that absolutely replicate this data. I don't have time to get into that right now. But what I would like to say is that the higher Caprini scores received extended prophylaxis. Now, what about COVID-19? It introduces a whole new measure of risk in these patients. And these patients, most of them are going to have post-discharge prophylaxis. And there's a recent report out that I just read the other day. It's nightmarish, the number of problems that people are having once they go home. Some of them on tube feeding, some of them on oxygen, not able to ambulate with a cardiac and pulmonary insufficiency. It's really a terrible thing. And so this brings me to the next thing, which I am frankly astonished that the authorities haven't endorsed. Now, while we endorse the Caprini score as in our COVID-19 guidelines for the American Venous Forum, one of the reasons for that is that there's thousands and thousands of hospitals all over the world that use this score, so you can't have them all of a sudden start to use another score. But believe me, the best data, there's some really good data out before COVID-19. ADOPT, Magellan, Mariner, Apex have all shown the value of betrixaban and rivaroxaban for the prevention of VTE in the medically ill patients after discharge who are at risk, especially using the improved D-dimer score, but also improve in Padua. And there is not an increased risk in bleeding. So my question for the authorities is, if all of this is proven in the non-COVID area, and I don't think there's anybody out there that doesn't agree that COVID is a higher level of thrombosis than the regular patients, why wouldn't you take the literature that we've already established, plug it into this disease, and then, of course, go ahead in your randomized controlled trials and test it out? But it seems to me that this is a very important thing to do, and I recommend that people take a look at these data very carefully. McDougall and Spiropoulos just wrote a very nice article in American College of Cardiology that was just published that outlines all of this philosophy. So in that regard, I'm sorry for the quick nature of this, but I greatly appreciate the honor to present before your society. And I would like to thank you for all of your attention. Don't forget, please, to go to my website, venusdisease.com, and please visit my YouTube site at Venus Resource Center for more information. Thank you very much all. You have a great day, and please stay safe.